Hi, my name is Lihteh, and I'm from San Jose, Costa Rica. I'm a retina specialist, and on behalf of the Subthreshold Ophthalmic Laser Society, today I would like to talk on subthreshold macular laser, the basics. Before moving on, I would like to disclose that I have received lecture fees from Quantel Medical, which is one of the laser manufacturers, and other companies that are not relevant to laser treatment. So, why are we talking about subthreshold macular laser treatment? In essence, is to try to eliminate the iatrogenic damage from conventional macular photocoagulation. And conventional macular photocoagulation is equivalent to continuous wave photocoagulations. Here in the images, you can see the long-term effects of patients with diabetic macular edema that were treated appropriately with conventional laser macular photocoagulation. And you can see that the laser scars have expanded, and then there's also some subretinal fibrosis. And even though the patients do not have any residual macular edema, the patients are not happy with their vision. Many years ago, Martin Meinster reminded us that conventional laser photocoagulation causes significant chorioretinal damage even when properly performed. However, he mentioned that this damage could be decreased by changing laser parameters and clinical endpoints. So I mentioned previously that conventional photocoagulation was equivalent to continuous wave photocoagulation. So every time that we turn on our laser machines and select power and a duration uh, of the power shot, once we press the button, the pedal, uh, the tissue is heated to the desired laser power selection for the entire duration of the pulse. Meinster has shown us that by modifying the exposure times, we can also modify the lateral heat expansion that occurs with each laser burns. For instance, if we look at this diagram, which shows the different tissues and different curves, you can see that there is less lateral heat expansion if the exposure times are reduced. Before we go on, there has been recently some confusion regarding names. So, because of patent issues, micropulse is patented by Iridex, whereas subliminal is patented by Quantel Medical. But in essence, micropulse is the same technology as subliminal. Both are subthreshold modalities of laser treatment. However, you have to be aware that not all subthreshold modalities are the same as micropulse or subliminal. The rest of the talk, we will be talking on micropulse or subliminal laser technology. So here we have another diagram which shows what we mean by micropulse. Micropulse means that each laser pulse can be subdivided in thousands of small pulses. And then we can manipulate with the laser what percentage of time we want the laser to be delivering heat and what percentage of time we want the laser to remain off. So by doing so, we can actually decrease macular damage. And I want to remind uh, the viewers and listeners of this talk that micropulse or subliminal laser treatment is a macular treatment, We are not talking about doing micropulse or subliminal laser treatment in the periphery as uh, different choice for PRP. That is completely different. Let me introduce the term duty cycle. So, the duty cycle is the expression of the energy delivered on tissues, the percentage of time that the laser is on compared to the duration of the entire uh, pulse. So, when we work in the macula, a 5% duty cycle is what has been shown to be the safest and effective of the different duty cycles that have been uh, studied. A 5% duty cycle means that the laser is delivering heat 5% of the time, and 95% of the time it is off. So when we see this graph here, we can see with a 5% duty cycle, the tissues are receiving the heat 5% of the time, and then 95% of the time, the laser is off, which allows the tissue to cool off, and then we don't have iatrogenic damage. And then we repeat the pulse again, and then we get 5% the laser is on, and then 95% of the time the laser is off. The ideal micropulse laser should have yellow wavelength, multi-spot or pattern technology, and the ability to deliver a low duty cycle. So the question is whether or not the wavelength matters or not. So to obtain the best results with maximum efficacy and safety, the ideal laser should have a high energy absorption by the RPE in blood, or rather the hemoglobin, and a low energy absorption by the xanthophyll, which is the pigment present in the macular area. And here you can see different absorption curves of the different pigments in the back of the eye. And you can see here that with the 577 laser, there is an excellent absorption with melanin, an excellent absorption of hemoglobin, and here you have the xanthophyll. So this is really the yellow laser does not impact on the xanthophyll, whereas the blue and the green still have some absorption with the xanthophyll. The infrared lasers also do not have any impact on xanthophyll, but they do not really are not really absorbed by the hemoglobin. So it's harder to see a visible spot with the infrared lasers. So the wavelength does matter. The best is 577, and the reasons are because it allows to titrate power directly under the micropulse mode and allows us to reach a visible endpoint, which is difficult to use, for instance, with the 810 nanometers. Why is multi-spot technology important? Well, you see here, the laser uh, has a mechanical mirror that allows us to treat in the different patterns where the laser beam is deflected by two motorized mirrors to produce a pattern. Why is this important? Because it allows us to deliver confluent laser therapy, and we will show that this lowers the risk of under treatment with using the multi-spot or pattern technology. Imagine that trying to do a treatment with monospots when these burns are essentially invisible. And I have to remind you that the most common cause of treatment failure is under treatment. Our colleagues from Brazil look at a study where they compare a high density versus normal density micropulse and then a modified ETDRS laser treatment. And you can see from these tables from their study that the best results were in eyes which had high density burns, meaning no spacing between burns in the treatment protocol. So, again, imagine trying to place invisible spots one next to the other when you're doing multiple burns in the macular area. So, what are the treatment guidelines? We tend to use a large spot size since there's no intended thermal injury using subthreshold. You will use a relatively large 160 micron spot sizes in order to increase the treatment area and to ensure a dense delivery of the laser impacts. You will recall that in conventional laser, our spot size were only around uh, 50 to 100 microns. But here with 160, we can actually do this grid with no spacing in a timely manner. So here, for instance, here we have 25 spots with a spot size of 50 microns. If we intended to do a dense treatment with no spacing in between, we would need to do 81 spots. Whereas if we intended to do just the same 25, we can increase the size to 160 microns. You would ask me, if 160 is good, why not use 200 or 400? But the problem is, you will recall that each laser burn, the power deliver is the radiance is determined by the radius of the spot size to the square. So we would need a lot of power to do those higher spots to deliver the same energy. And unfortunately, the laser capabilities are not that high with the current technology. I mentioned previously that the duty cycle of 5% was important. This is a preclinical study by Victor Chung and colleagues where they look at different wavelengths and different duty cycles in rabbit eyes, and they saw that the most uh, efficacious and safe uh, combination was using a yellow laser with a 5% duty cycle. So again, with subliminal, what we do is we recommend using a spot size of 160 using the subliminal or micropulse mode, a low duty cycle with an exposure time of zero point 0.2 seconds using a lens that gives you around a magnification of 1. And we really recommend doing power titrations. To determine the thermal threshold, what we do is that we select a place outside the arcades, and then we start using the laser under micropulse mode with all these parameters and start shooting until we obtain a visible endpoint. Then we reduce by 50% the power, and then we use the multi-spot delivery mode to implement the treatment. A reminder, there should not be a visible reaction during the treatment. There is no need to change power with different degrees of edema. And again, the laser impacts must be confluent. You have to do a dense treatment. So again, the key characteristics of an ideal laser for macular work is that it is a subliminal mode, multi-spots, and have a yellow wavelength. I hope that this has been useful, and if you have any comments, please reach out. Thank you very much for your attention.